Today's presentation is titled Ending Maternal Death Due to Excessive Bleeding After Childbirth. Our collective responsibility with focus on Busoga region. This is our theme for this year. And I'm Pontian Chiwanuka, obstetrician from Iganga General Hospital, together with Dr. Xavier Robert, obstetrician working with the Nsinze Health Center for Namutumba District. And we are grateful to Busoga Health Forum for this opportunity. Let us go to the next slide. Next slide, please. Yeah, thank you so much. We begin with a quote. And this quote is from Worthy Living. The best argument to stop it, however, isn't economic, but ethical. So the postpartum hemorrhage, and this is excessive bleeding after birth. But for those the frontliners, you add more than 500 mils after vaginal birth or 1,000 mils after cesarean section, or any amount which deranges the vital signs of the mother. And we know that globally, we have 14 million women who experience postpartum hemorrhage, and 70,000 of them die. And we know that this death of mothers is preventable if all of us played our roles. When we look at Uganda, in the financial 2023-2024, we had 1,222 mothers who died during childbirth. When you delineate them, find that the highest number was in Kampala, and now Busoga, we came second. We lost 123 mothers within our only 11 districts. I think that is a full village of pregnant mothers that we lost. And the cause of these maternal deaths hemorrhage. This is excessive bleeding. Now, this percentage is for Busoga, but nationally it was only 36. But for us, we took a lion's share. And then hypertensive disorders at 16%. We have the indirect causes like malaria, anemia, HIV/AIDS, TB, and then others. But also, sepsis is with us, and it claimed 90% of the maternal deaths. We always ask ourselves, why mothers continue to die? And are they going to continue to die tomorrow? If all of us I think dying excessively. 80% of the maternal deaths are preventable. Now, this is the hope that we have, that we can prevent 80% of them. But then, why should they continue? Why do they continue dying? Delay number three, inadequate. Delay number three is brought about by inadequate quality care at health facility. When you see mothers dying at a health facility, it means the quality of care is really not the best. The entire Uganda, this one contributed to 62% of the maternal deaths. Busoga, we decided to go a little bit higher, and inadequate care caused 70% of all the maternal deaths. Delay number one came second, and this one is decision to seek care. The mothers take long. They are waiting for their husbands. They are waiting for the Senga to decide for them. And nationally, it was 55%, but in Busoga, we again went higher, and it took 56%. Delay number two came third, and then this is delay to reach health facility. The transportation bit of it and the delay in referrals caused 39% of the maternal deaths for Busoga region. And as I'm speaking from Iganga, that financial year, as a hospital, we lost 13 women during childbirth, but 61% of these were due to postpartum hemorrhage complications. Next slide. So this is a pie chart to show the mothers that we lost in 2024-2025 financial year and the causes of death. You see, postpartum hemorrhage caused 61% of the deaths, and then followed by hypertensive disorders in pregnancy, and then acute kidney injury and pulmonary embolism. They came. They had the same share. Next slide. So, but this, we have to end PPH-related deaths. If we could end this, we shall reduce our maternal deaths to a significant, to really a very low level, and we shall be able to attain SDG 2030, that is target 3.1. So what do we have to do? Facility readiness, availability of human resource. We have a problem everywhere of human resource, but there are some facilities which are really suffering a lot, and therefore inadequate care for women leading to death. And then we have timely use and correct doses of PPH management medicines. Some facilities don't have them, not because they can't afford them, but because of the health workers have not given them priority, and therefore mothers die. And some of these, we have oxytocin, which should be properly stored, because if it's not properly stored, it is like a placebo, it doesn't work. We thank BHF that helped us to secure heat-stable carbetocin, which doesn't need refrigeration, and I think it has done wonders. Misoprostol should always be available, tranexamic acid, and IV fluids. If any smoke facility or any facility that conducts deliveries and it doesn't have all these drugs, then it's better that facility closes. Next slide. May I call upon Dr. Isabirie to take on from here. Thank you very much. Host, please help to unmute Dr. Isabirie.
Dr. Savri has the right to unmute. He just needs to unmute and then speak to us. Dr. Isabel, are you able to unmute? You have the rights to.
Benji, I think you gave me the rights, but there's another Isabel you should be giving the rights to unmute. Isabel, who is with Isabel at something dot, I think.
Yeah, he has the rights too.
But Isabel at 2016 something. I think she's the one.
Yeah, still he has the rights. Dr. Isavier Robert, are you able to unmute and speak to us?
I think I
Yes.
have unmuted. Am I heard?
Yeah, you are now heard,
Okay,
please.
ladies and gentlemen, I have been introduced, I think, twice by Desmond and Pontian. So I will go direct to the gist of the matter today. So today's presentation is actually an advocate presentation calling everybody to action to end preventable maternal death due to excessive bleeding after delivery. Each of us is a stakeholder. Therefore, if each of us plays a role, the Busoga will be at a different level. The woman giving a life shouldn't lose hers. That kind of butter trade shouldn't be acceptable anywhere. So each of us can do something to end the preventable maternal death due to excessive bleeding after childbirth. Why do women still die from PPH? I think we have seen that the three delays. Delay in recognizing danger signs, making a decision, delay in reaching the facility, and the delay which really concerns the health workers directly, which took a lion's share of about 70%. So I will highlight a few stakeholders, but we have to understand that each of us is a stakeholder. Whether you are the chairman of C1, whether you are just a neighbor to a pregnant woman, you are a stakeholder and you can play a very big role in preventing maternal death. So what's the role of Parliament here that we expect from them if we are to end maternal death? Our parliamentarians from Busoga who have logged in, you need to allocate budget to Minister of Health. Whenever the Minister of Health tries to bring our budget to the floor, please support it wholeheartedly such that we can prevent our mothers. Can you imagine 123 mothers dying? That can cause over 300 orphans. And it is causing 123 widows in the region. Eventually, economically, it will affect our population, and we shall keep lagging behind whenever they release indices of poverty. Minister of Health, support Minister of Health policies. For example, if they suggest that we are going to upgrade health facilities from level 3 to level 4, Parliament is expected to support that. Therefore, I'm calling upon our parliamentarians from the region to advocate for as many as possible lower facilities to be upgraded to higher facilities such that we can offer better health care. Support economic empowering programs such that the population is empowered economically and therefore they can easily reach the facility because they have the transport, they can easily afford to buy whatever they need to use in order to prevent what? Maternal death. The Minister of Health should formulate policies. For example, the staffing norms, advocating for the wage bill. Why should a hospital like Ujiri have only one anesthetic officer? Simply because the staffing norms say there should be an anesthetic officer. We expect Minister of Health to come up with a policy to change that kind of structure such that we can have 3 or 4 anesthetic officers in a hospital and at least more than one in a health center 4. But as we talk now, we have one anesthetic officer at a center 4. Supposing she goes for maternity leave, will such a facility be ready to handle emergencies due to excessive bleeding? And how shall we avert such a problem? We also expect the Minister of Health to develop PPH guidelines, disseminate them, and train orient health workers such that they can be able to respond appropriately, give adequate interventions in order to save lives. Supply chain to ensure that we have supplies like oxytocin, tranexamic acid, sutures. For example, if you look at my facility in Kinze, the nearest pharmacy is in Busembatia. So if a mother came with PPH, and we decide to go in for surgical intervention, but we have stock out of sutures. How long will it take? That's why you see that the third day is actually affecting the Busoga so much. Strengthening the referral system. Minister of Health is expected to ensure that we have ambulances. These ambulances should have fuel, and we should have trained staff to accompany the patient such that there is no interruption, discontinuity of care along the transfer from the lower facility to the higher facility. In a study we conducted at Kawente, we found out that actually patients who are not accompanied during the referral were at a higher risk of getting an adverse outcome compared to those who were transferred in an ambulance with the healthcare provider on board. We also expect of heritage to carry out the surveillance and response. The response is very important. This very week we are reviewing the maternal death, and we were told that Kalisizo Hospital has one anesthetic officer, and the challenges started from around there. We expect a response. Ministry of Health officials who are here on this call to look into that, such that whenever we get a case of maternal death, it should be a learning experience to avert similar maternal deaths. At the district level, as stakeholders, the DHO's office, we expect recruitment of critical staff. Take an example of a hospital like Kegang, having over 300 deliveries in a month, and it has around 20 midwives. 5 are in antenatal care, 2 are in family planning, there are 3 in cancer screening and what have you. Then you are left with maternity and postnatal, left with around 80 midwives. How shall we ensure that such a secretary staff provides adequate care? We expect DHO's office also to offer support supervision to the lower facilities in order to strengthen their capacity to handle emergencies. Support referral systems. Quite often, facilities struggle with referrals because they don't have fuel, somebody doesn't have airtime to call the ambulance, and so many challenges. Then we also expect them to build the capacity through mentorship and ensure that facilities are ready to handle PPH emergencies by ensuring that supplies like the nurses, balloon tamponade, blood products, giving sets are available, appropriate medicine and summaries. For example, we talked about the medicine, Dr. Pontian talked about the medicine for managing the PPH. If we have a stock out of oxytocin, we don't have misoprostol, and we don't have carbetocin. By the time you tell the attendant to go and buy, you have lost time, and therefore that tantamounts into the third delay. And most likely, the reason that's why we have higher maternal deaths within our region. Now for us who took the line as the health workers, we are expected to be monitoring mothers during labor, not only monitoring, but also we should interpret what we are monitoring. We are taking the blood pressures, and you are seeing the downward trend. What else should you do? You are taking the pulse, you are seeing that it is raising. You should interpret what does this mean, and what do I need to do? You should have skills to identify the different causes of maternal, of PPH. For example, cervical tear, and if you can repair, you should know how to repair. At the facility where it can be repaired, we should have people with the skills to repair the cervical tears. At facilities where we can't repair, we should have the skills to clamp and refer the mother safely to the next level where such a tear can be repaired. We should have skills to carry out cesarean section. Not only cesarean section, but also surgical intervention in the management of PPH. For example, every doctor who is doing the cesarean section will be able to apply a D-ring, to be able to do a subtotal hysterectomy to save a life, to be able to do the O'Leary stick, such that in case you have gone in for surgical intervention in the management of PPH, you are able to save a life. Instead of you referring a bleeding patient and the other receiving end receive a moribund or possibly a death at arrival. We should improve our antenatal care such that we prevent anemia, because no anemic mother is at risk of PPH. Any amount she loses will lead to derangement of the hemodynamics. We should be able to identify mothers who are at high risk and therefore plan appropriately such that we prevent emergencies and in the long run prevent maternal death. At community level, we should sensitize the communities on health-seeking behavior in pregnancy. We should be able to address teenage pregnancy. We should offer family planning the population such that you prevent cases which are at high risk of PPH, for example, the grandma para. We should train our mothers during antenatal about birth preparedness, the birth preparedness plan. The mother should be where will she deliver from, with who will she go with? Does she have transport saved such that in case she goes into labor or in case she's referred to the next level, she does not waste time on looking for money here and there and reach the facility there. The issue of traditional birth attendants, I think this needs a multifaceted approach such that, because most of the time as facilities when we try to intervene, the politicians come in. So possibly we may call on the Minister of Health to come up with a policy, since the issue of TBA was a policy from Minister of Health. Much as it was phased out, the remnants of that policy are still in the community. And possibly we need another policy to erase them out. We need to address the myths about pregnancy and delivery and address health workers' poor attitude, which is likely to send away mothers from the facilities and they end up in the hands of traditional birth attendants. In case of any maternal death, as facilities, we need to review timely reviews such that we learn from the experience and be able to prevent further cases from happening. Use of protocols, job aid, and the national guidelines as we talked about means of health providing, such that we can provide standard care to our mothers with PPH. Ensuring commodity distribution such that we allocate commodities where there is demand, other than leaving them lying idle in other facilities, for example, in the health center 3, when the health center 4 has a shortage. We need to address the referral system. So this one is addressed at different levels. As a facility, we need to budget for fuel. We need to have health workers who can accompany our patients. We need to know how to apply a nurse before you refer as part of pre-referral management. You shouldn't refer a mother bleeding without a cannula. And this is a common problem with the health center series. Even last week, this week, I think, when Kamuli was presenting, they had a mother, they had put a pediatric cannula, yet the mother was bleeding. And eventually they lost the mother. It used to be a problem. I think it's a problem with the procurement that we need now to change. Nowadays, it used to happen, but when we moved around as DHT and the talk to daily charges, right now, all the health center series providing delivery have large bore cannulas. Otherwise, conducting the delivery without a large bore cannula is like attempting to kill a mother because you don't know what will happen. So we need to address infrastructure at facilities. We have areas for high dependence units where we can monitor mothers who are very sick, because a mother who has delayed may need more intensive monitoring than a mother who delivered normally. What about the NGOs? NGOs need to come in and fund equipment, fund training such that we build the capacity, support innovation They can as well help us in transport, giving us an additional contribution towards fuel in the case of referrals, and we need to also expand community outreaches such that we can reach out to the people, teach them the benefits of having a supervised delivery, demystify any myths about the pregnancy and childbirth through their support. The local leaders and religious leaders need to mobilize with us the community together. We have seen cases where a mother with 4 previous scars is carrying the 5th pregnancy, and she tells you that the pastor prayed for her and told her not to go to the hospital. Any pastors, any religious leaders on the call, please, as you pray, encourage these mothers to come to the facility such that they can get appropriate care. We need to advocate against those delays where we believe that only a man can make a decision. So we need to empower women to have autonomy in seeking health care, such that in case a mother goes into labor, in case a mother gets any eventuality like bleeding, she can seek care even if the man is not around. We need to involve men in care for these pregnant women. Quite often when we interact with the women in antenatal, we give them the right information. But when they go into labor, they have no control over the situation. The husband will put on a motorcycle, and wherever he goes, that's where they will end. So you end up taking the mother with a pressure scar to a TBA. And I can assure you, the outcome may not be good most of the time. So, as I told you, everybody is a stakeholder. Even you may say that me, I'm not a religious leader, I'm not a health worker, I'm not a DHT. What is my role? I said, even you talk with your neighbor, asking your neighbor whether he has accompanied his pregnant woman to antenatal at least once is a contribution enough to prevent a potential maternal death. So August next month is our PPH awareness month. Therefore, each of you should be prepared to do something. Make a contribution towards preventing maternal death due to PPH. Just like the gospel song goes, go tell it on the mountain, over the hills and everywhere, that the leading cause of maternal death is excessive bleeding after childbirth, and it can be prevented. And we can save 80% of the mothers who die because of excessive bleeding after childbirth. Thank you for listening to me. I hand you back to Desmond.
Perfect. Thank you so much, Dr. Isaac. And I want to really appreciate the great work that you're doing within the whole Busoga, even you're based in Mutumba. We really appreciate. I want to also appreciate our own Dr. Pontian, who is always here to see that the lives of the mothers are improved. I know mothers must be happy, but even the men who are here, they should be happy that today is the people whom we are having on call are supporting a lot of lives to be there. I know there are very many people in this field, and we should all really think about this, the mothers who are dying. These numbers may look to be statistics, but these are our sisters, these are our mothers, these are our wives. So it's unless it comes to your house that you realize how the impact is. So we should always fight that it doesn't come in our houses. We all have a part to play. We stakeholders in reducing the maternal deaths that we are having. So it has been a good presentation, and I know people who are here are having comments, are having questions that we want to add on to this. Very many interventions are being done, including from right there from the Ministry of Health. The ministry has done much work to see that we reduce on the maternal death. The 3 delays are real, and these are things that starts with us. The 3 delays start with everyone who is on call here, that we can do it with them. All of us are stakeholders, and all of us can play part in giving out the knowledge. Just like doctor says, go and preach. Let's use the verses. we go and preach. If you preach to one person, then it moves to the other. So let us all become preachers of this gospel. And just as Doctor said, we're beginning the PPH awareness month. Just right now, I've just received a message that we need to prepare a presentation about a PPH, and I know very many people here would wish to do this. I've seen even Dr. Ameka here. All these people are doing out of work. So with this, I want to open this to the members who are here, that we can ask questions, we can put comments, but once again, I want to apologize that the people who are on call, for those who have been attending, this is not our usual way of doing things. It was beyond our control at the same time to begin late. I can open it to questions. For the CPD link, I'm going to share it in the next 5 minutes. So we just keep that, we just be patient. I can have Ngovi Alex. Alex, could you unmute? Ngovi Alex, I'm giving the permission to unmute just shortly. Perfect. Alex, can you unmute now?
Thank you very much. I'm very grateful to be on the platform and to listen to our professionals, doctors and specialists. My concern is mainly on the community-related delays. I'm sure the midwives have tried. Community, we have two kinds of people who can preach very well the gospel. One, they are health assistants or health inspectors. They need to be facilitated with a cause like a full sub count, but is not given a count and preach the gospel. Another group is about the VHTs. The government talked about the VHTs and giving them some sort of transport like a bicycle, because you find that they sit waiting for the client to come, but the clients are not reaching. Why? They are delaying to make a decision. Which decision is they need to be talked about, because the aunts, they don't come for antenatals. For them, they say, let us do this. Let me give you an example of like this place of Usede. Of recent, the mother died because of the aunts and the wishers who giving advice. But the VHTs were there because they don't have that information. They were just looking. The mother ended up passing on, and they were called for burial. Reaching there, that was the issue. So those two groups, they need to be facilitated and isolated, because midwives, I'm sure they do their work at first level, doctors do, clinicians do, nurses do, but what about in the community? Those people in the community.
Yes, thank you so much, Alex, for that comment. That's very real. We saw about that in the people who said that's in the district. With that, I want to comment to politicians who are on call here. Can you be stewards of having that reduce maternal hosts? When interventions come up, or when we said that we are going to centralize ambulances, we're not taking away ambulances from your facilities, but we want to see that they serve the whole population. In your district, you need to work on this. Let me have Rose Naviri.
Thank you, moderator, and thank you, the presenter, for this wonderful presentation. Mine is on referral. I think I joined when the doctor was saying that the women who are referred without accompaniment, they are more likely to get into problems. And this one is, of course, it is known why there is nobody who is monitoring and so on. However, recently I talked to an ambulance driver, actually in Jinja district, and he was telling me that sometimes he's called to take a patient to a referral, but then because there is only one midwife or one person, and it is at night, then they want him to go alone with the patient because the midwife cannot leave the facility without someone. I think we have a problem. We need to really advocate for government to recruit more staff, more midwives, because under such circumstances, what does the driver do? He knows nothing, and then he's supposed to go alone. So for me, I advise that you don't risk moving with a very sick person when you are not trained. You just insist that you have to go with the midwife. So the situation is really not good. Thank you. Over to you.
Thank you so much, Professor, for that insight. Can I have Zaina Kauma, then Kenneth, and we can, that will be our first round of questions. We can have others after others. Yes, Zaina.
Thanks so much, our presenters, our specialists, for that wonderful presentation. Mine is a bit community-related. I'm a health inspector by profession. We have challenges. It's good we are going that awareness month, PPH awareness month, and I know we are working even with the ministry and other partners. So how are we going to address this issue of TBAs? Because it has become a problem. However much sensitized communities, these mothers attend antenatal to access services from health facilities under supervision of qualified personnel, but still they go to those TBAs. So as ministry, we've talked of policies. I don't know how this can be handled, but it's a patent issue. Because we're losing lives. And sister, the former president has talked about the referrals. But you find that these referrals, some are coming from TBAs. But they hide. They say, you don't talk about TBAs. You say, I'm from this facility near here. And when you request for a referral document, they said they were not given. But in actual sense, when they're from TBAs. But they come late, even in worse conditions. So I don't know. I'm not talking about the men who are on this group. They are good people, but we need more involvement of male involvement. Need to be done on male involvement, because with men, they know the pregnancy takes 9 months, but you find that they leave these mothers, all these pregnant mothers, with nothing. A mother come not having anything. You can't anticipate those people who will be worked on. Like for example, Rasigang Hospital, in a month you can deliver 600 beyond mothers. So you can't anticipate whether the supplies which were given to a health facility will be found by that mother. You can't know which number is going to be attended to. So they need to have that extra budget in preparedness with them. But the men are stubborn. Some men are stubborn. He said, I will provide you anything after me seeing the baby. So they have to change attitude. And yet they really need what? The children. So we are doing a lot, but supplies, I don't know how facilities are going to address supplies. The other facilities have tried to address it, but still a challenge, because it gets what? We get those stockhouse, and really it is challenging. Thank you.
Thank you, Navi. Navi, you are what's your title and where do you work? Kindly. Navi, do you want Navi? Sorry, Kauma Zaina. Where do you work?
Kauma Zaina, I'm health inspector. I'm based at Igala General Hospital.
Okay, thank you. Can I have Kenneth?
Thank you, Chair, and thank you, colleagues on the call. Good evening. Chair, before you ask, my name is Kenneth Mutesa Sida, and I work at WHO Country Office. I'm particularly interested in the health of mothers across the country, but of recent, we've been doing some work in Busoga, And I know there are some health system elements that have been touched, but like some have said, having buildings, having the ambulances running is not enough. So I want to thank the specialists for the presentations. And somebody asked about TBAs. We had an experience shared from Teso region on Thursday. And I think it is something that we need to look at and see how we address engaging the TBAs, maybe to become referral agents, but also the community. I concur with that. For the presenters, I just wanted to mention that as we continue to work around the processes of care to improve the quality of care, I think there is going to be need for increased emphasis and focus on the issues specific to Busoga, the commonest issues that we are seeing in our MPDSR, so that we have very specific actions. For example, the issues around clinical management systems. Some sites would say, oh, we have one midwife on duty, but when there are several midwives, but probably the scheduling of those midwives. It is true there is a shortage, but sometimes it's a management issue that needs to be looked into. The other one is for us to think through how do we saturate the region with skills for our frontline people to perceive risk, to make a diagnosis, to be able to do some pre-referral care like Dr. Isabidi and Dr. Pontian mentioned, even to manage. How do we saturate our CMOCs with skills? I think these are things that we also need to think about as we move forward. Otherwise, I want to appreciate the ideas around community engagement and also the engagement of all the stakeholders, but we need to saturate the region with skills to identify and manage, but also to know that any mother can develop PPH. I like the point Dr. Isabidi mentioned, that as you deliver a mother, you have readiness. On supplies, again, this has been chronic, but I remember when I worked in
Dr. Kenneth, okay, perfect.
Okay, somebody had muted me. I'm saying that I remember we used to admit like hundreds of children every day, but sometimes from the store you'd get only 20 cannulas, and so many children would need cannulas. So even as we continued advocating, we learned that those 20, as you support one patient, you try to tell them, please prepare to get us a cannula so that we can support the next patient, so that you don't totally run out, get a person who needs it, and then you are trying to send them to the pharmacy. So I think the way we need to be very proactive with what we have, and then to see how we can be able to support our patients.
Thank you, Dr. Kenneth. Before I have another Kenneth to come and speak to us, let me ask the team to first respond to those comments before they forget them. Yes, Dr. Pontian or Dr. Isari. Dr. Pontian.
Thank you very much. I shall comment on a few that including Dr. Isabidi also comes in, but also we had comments in the chat. How do we bring the private practitioners on board? I think this one goes to our leaders, our DHOs, ADHOs, and also facility leaders. We need to call these private practitioners because at times also when you go to supervise them, you find that they are really doing a substandard work. But how do we bring them on? We request our DHOs, ADHOs, and facility in charges to come in and bring them so that they get the skills. Then someone was talking about use of ergometrin. Ergometrin is used in the prevention of PPH, but when PPH comes in, we prefer using managing it using oxytocin, misoprostol, and then the motive bundle. And then the community related delays. We really need to engage the community as Kenneth said. And in the PPH awareness month, we are going to enter the community the churches, in the markets, wherever people are
Can't get you clearly.
gathered,
Breaking.
we are going to go there and tell them so that they know and they seek for healthy interventions. And then also there was a comment.
Okay, Dr. Isabel, could you be taking up some questions as we get Dr. Pontin back?
Thank you. Thank you, members, for those comments. Most of the actually there is no question, they are just comments, and it means that we are sharing actually the same challenges, and therefore I'm happy that the purpose of this advocacy presentation is being achieved because everybody is realizing where we are and what we need to do. Responding to Dr. Navide about the referral. See, we have similar situations, for example, where ministers keep saying, don't give anesthesia when you don't have an anesthetic officer. But you find yourself having a patient, and you know that this patient will not reach the next destination, but you don't have an anesthetic officer, and they end up giving. So it is a situation where you cannot give a straightforward answer to the driver, because assuming the driver, the midwife on duty has like 6 mothers in labor, and the 6th mother needs to refer. Will she leave the 5 behind? It is a question to all of us. So there is no outright answer to that question, that situation, but you handle it the way it comes and you see how you get out of it. Zain Nakauma is a community person actually. And in most of the districts, the health inspectors coordinate the VHTs. Therefore, since we have said everybody is a stakeholder, I think starting from tomorrow, she will take a lead in organizing the VHTs towards this cause, sensitizing them such that they can sensitize the community. We thank the Ministry of Heritage. She has come up with a policy of community extension workers, though it is still in the pilot district. It is in the pilot phase, but we believe it will be scaled up to other districts as well. And these people are trained a bit extensively compared to the VHT. And they're equipped with knowledge and even equipped with some instruments like BP machines, thermometers, weighing scales, such that they can be able to detect some danger signs within the community. So we think that's a step in the right direction. Dr. Kenneth Mutesasla, I think I concur with you that some facilities have enough midwives. For example, there are some health center force with 10, 12 midwives, but you find one midwife on duty. That means the problem is within the facility, and therefore we implore the leadership of such facilities to come up with measures, interventions to avert such situations. However, there are facilities which are genuinely bad law. You find a health center for with only 4 midwives, and it is conducting over 200 deliveries with over 50 cesarean deliveries in a month. So in such cases, you find one midwife is on duty. I don't know that we are still getting. In such situations, you find you have one midwife on duty. He's supposed to offer antenatal. At the same time, supposed to look after, monitor those who are in labor, and at the same time go to theater and receive babies. The situation becomes a bit challenging. I think those are the comments that we are raised. Over to you.
Thank you so much.
Desmond.
Thank you so much, Dr. Robert. I know we overstretching. I want to invite Dr. Paul Chireng, but before he comes, I think himself will make an emphasis on this. John says, please hit on the emphasis of doing scans repeatedly and follow-up scans for mothers. Many placenta accretas, I think, are being missed and then found on table, yet the person delivering has limited training and skills in managing the incretus in the facilities with in the facility, which is too far away from the referral. So Dr. Paul Chirenge, could you make an emphasis on that before you ask or comment? Over to Dr. Paul Chirenge. Yes.
Oh, thank you so much. Really, we need to emphasize doing ultrasound scan, and we also need to really see where scan being done, because some people have really misdiagnosed the mothers. Tells you there is only one baby, and we find there are two. We have seen gastroschisis, babies with congenital abnormalities when they are misdiagnosed. So we need to emphasize ultrasound scan in pregnancy, and also the first trimester, second, and also third trimester. And we encourage people to do the anatomy service scan at 19 to 21 weeks. That one can also be very, very helpful. And facility managers, health center force, you don't have a reason why you don't have a scan. Please keep irritating your district to provide the scan and also someone to work on the scan. Health center threes, send the mothers to do scan, but also if you can have one, it is far better. So every mother should be encouraged to do a scan. It is cheap, 10, 15, or 20,000. A scan can be done. Let us encourage our mothers to do those scans, because we need a minimum of 3 scans on the pregnancy. First trimester, second, and also third trimester. Thank you very much.
Yes, let me have Dr. Paul Chibeng.
Hello, thank you very much for the presentation, and a lot of thanks to my colleagues, Dr. Chwanka and Dr. Isabidi, for the effort you are making. I think it's really frustrating for them, all the other doctors and health workers, that you learn how to save a life and then you are frustrated by the process of saving it. Not that you didn't know what to do, but because you don't have what to use to save the mother, either in terms of material or in human resource. But when I looked at the problems you have from a 5Y perspective, is you have to understand that this is a decade of problems. Yeah, it's good we are in an election season, that people are electing for leaders. Yes, the leaders you are going to send are the ones that determine the policies that are going to govern the system. So the people you are sending either to parliament or on districts, they are going to impact so much in how much the region can achieve, or what they can do, or what they can help the constituents. That is the first part. Because if the parliamentarians cannot have a voice that increases the budget that is allocated to the health system, then you are going to raise your concerns about the shortage of health workers. And in the end, they are going to tell you that, yes, in this financial year, the money we have cannot allow us to hire. Okay? Yeah, there is a person who talked about management. Yes, management is very key in the problem that you have discussed. So that is from the source of the funding that is going to help to hire, to recruit the health workers. Now, on availability of health workers, I can tell you that Busoga per se now, we have so many training institutions for the midwives that we will not be, or any facility will not be lacking health workers. Actually, for parents who pay money painfully to train their children, Lubega Institute is producing health workers everywhere. You go to St. Eliza, you go to St. Elizabeth, you go to all the facilities that you can think about. They are training so many health workers. So for a parent who trains a child and they try to get a job and they get frustrated simply because the recruitment system, people are going to be asking them to give money and then they don't even get the jobs. It is really very frustrating. I remember one of these days, the PS was saying that one time they advertised a post for MOs and they had so many that applied, even more than what they wanted. So that is for medical officers or for doctors. Now you can imagine how many midwives and how many nurses are unemployed. So that means that the issue is not availability of workers. Personally, when I was an intern in Ginger Hospital, we used to train so many nurses who were training alongside us on the wards. But when you find out, you follow them up, most of them will end up in working in drug shops. Others are working in nursing cheaper than the ones in Mengo Hospital. They end up diverting to different areas because of the frustrations they get for being recruited. If someone is asking you for kickbacks to get a job, some of them will not have the money to be hired. And then you'll hear at the end of the financial year that district, a hospital, has returned funds for recruitment back to public service because they were not used. So the whole thing, I think, will start from the management perspective before it gets to where you can find a solution to health workers in these facilities. Right from the source of the funding, the government allocating the money, and then a clear recruitment system for people to be able to get jobs. Otherwise, it is starvation amidst plenty. There are so many health workers who don't have jobs, and it is a shame that you can say that we don't have health workers in facilities. That is my comment.
Thank you so much, Dr. Paul. This is quite insightful. Today, it has been really talking about the issues. You know, we always have sessions to learn, but today, everyone who is here saying that you have a role to play. I want us advocate for the ways that we improve the care for our mothers. As we have Kenneth to ask the last question, I want to ask Khadija to be ready to give a vote of thanks to these good people. Yes, Kenneth. Okay, you brought the hand. Dr. Ponti and Dr. Isavile, could you make the last comment as Naka prepares the vote of thanks?
I would like
Thank you very much. As Dr. Isavile comes in, my comment and my last word is that everyone has a role to play. Let us rise up to address the killer. Let us rise up next month to do awareness to each and every one. We must overcome PPH. Thank you so much.
Before Dr. Isavile, Kenneth, do you have a question? Because
yes, I do.
Please go ahead.
Thank you so much, Chair. This is Wamika Kenneth, pharmacy, Namtumba District Local Government. Mine is not a question, but an insight. I want to speak to during the discussion, during the presentation by Dr. Isavide and Dr. Poshan, an issue of supplies has come up, and this is a recurring issue. But to me, as a supply chain person, one of the things I can give or put to this is, let's try to get on board when it comes to terms of procurement planning. Because what happens, in most cases, the planning is left to individuals, certain individuals, and we supply chain persons, we may not be well conversant with what you always require in your defined departments. But when you come on board and we have that discussion, we can prioritize certain items and be able to improve on the quantities. Let me say, for example, MCH department. So if you don't come up and we have those discussions, you may find that I'm ordering to an examic acid, maybe oxytocin in little quantities, maybe yellow cannulas instead of maybe ordering more of green or gray. But when you come up and you give me the rationale of why we should order for more of those, we can ration the budget and increase on those quantities. Because what happens, procurement planning happens once in a year. Like, for example, it's coming December or January this year for the next financial year. So if at all you don't get involved, quantities are going to stay the same, and we shall continue crying over this. The budget may be low, but if at all we come up and we prioritize on certain items, we can be able to serve our mothers very well, and even our key patients. Lastly, what I want to talk about for the managers or who are on this call, I would like to advocate for thinking about employing more of the supply chain personnel on this in our different districts, because previously it has been IPs who have been managing this, but now IPs are moving out, and now it is coming to districts and hospitals. So we need to strengthen this by bringing more of these supply chain personnel, qualified ones, to advise us on how we can run this, because it is a key area. More of the money is put into this area, but the persons or the personnel managing most of these things are not well conversant with what is going on, and that's why we have some of these problems. You may find that items are expiring, they were over ordered, and yet they were not supposed to be. So I beg to submit, and thank you very much.
Thank you so much, Kenneth. That has been much advocacy. Can I have Dr. Isabelle?
Thank you very much. I would like to first of all appreciate all the members who took off their time to log in and listen to us. I would also go on to appreciate the Busoga Heritage Forum and the Rotary Club, who have given us a platform to create a network of ambassadors who will help in the fight against maternal death due to excessive bleeding after childbirth. We are now all ambassadors towards that. Therefore, every day, you need to ask yourself a question: what have I done today that can help prevent maternal death due to excessive childbirth? In whatever docket you are, in whatever capacity you are you a doctor, are you a nurse, are you a midwife, are you a teacher, are you a politician? What have you done every day? These small steps will lead us somewhere. Lastly, Dr. Mutesasira asked a question that I would like to request Dr. Wameka to come up with the answers. Not now, that will be forwarded to Dr. Mutesasira and possibly the entire team in Busoga, that what can be done to extend the skills to all the smoker facilities in our region. Dr. Wameka, hope you take note of that question. You can take that as a take-home message, such that we can suggest answers and get in touch with Dr. Mutesasira later. Thank you very much, ladies and gentlemen, for listening to us.
Thank you so much, Dr. Issa Abidie. And Dr. Meka is here, and I hope he has got his homework. I know he's somebody who works very hard. Right now, let me invite Hadija Nakatude to give a vote of thanks. Hadija. Yes, Hadija. You're mute. Perfect. Okay.
Thank you so much, Desmond. I didn't know that I was supposed to do this. However, I am humbled to be part of the call, and to the colleagues that are listening in, thank you so much for sparing that time to join in. Before I give my vote of thanks to Dr. Isabi and Dr. Pontian, I extend to you greetings from the Ministry of Health, Reproductive and Child Health Department, and specifically from the NASMEC PPH subcommittee. As you heard the speakers speaking, they were saying that we are preparing for the PPH Awareness Month, and of course we know August. It is about PPH. We want to speak about PPH. We want to speak about excessive bleeding after childbirth, to the families, to the communities, and to everyone that is in our circles. So I thank you all. Just to remind us all that the theme for this year 2025 is ending preventable maternal death due to excessive bleeding after childbirth, our collective responsibility. And of course, when we say collective responsibility, we have the health workers, we have the political leaders, we have the mothers, we have the fathers. Name it, everyone. We want to make sure that the message gets down to even the last person, so that they get to know about postpartum hemorrhage. Busoga, one thing that I know is I have been trying to coordinate activities related to PPH across the whole country, but it so happens that Busoga region is a little privileged, because apparently we have had like around 2 programs that are running and they're supporting PPH initiatives. One is the Safe Birth Africa project, and it is a project that is supposed to be implemented for 3 years. And I know Dr. Bameka knows about this. And our target, at least, is to make sure by the 3 years we have all the health center 3s trained on PPH prevention, and also what we call the emotive first response bundle. And then also another project that I think some of you know who are also on the Busoga Health Forum is the Catalytic Opportunity Fund, that basically looks at supporting capacity building on the 2 NLAM commodities, that is heat-stable carbetocin and tranexamic acid, and it is implemented by Busoga Health Forum. So as a region, we have an opportunity really to rally behind what we have from the ministry and also the support partners, to make sure that we put a dent on the PPH cases. And also something to note is we have so many teenage pregnancies, and we also know the relationship between teenage pregnancies and then postpartum hemorrhage. So I also think that is something that we must not leave behind. Let us make sure that the young girls, the teenagers, get to know that, yes, it's not just about giving birth, but you have, I may say, you have an opportunity to develop PPH if you give birth while you are still very, very young. And Dr. Mameka and the other colleagues, we have so many health centers where we have clinical officers that are leading, but we are not seeing the clinical officers on board. And I want to thank the last person who talked about issues around procurement of the new commodities, and maybe any other drugs, issues around planning and budgeting. You find facilities that are led by clinical officers. The midwives give us feedback that they try to tell them that we have this particular new PPH commodities. Can we please order for them? And then the in-charges, who are clinical officers, do not know these things. And this is just my appeal. When we are having trainings, please, the clinical officers, we are kindly begging that you come on board. And also not forgetting to support the very, very critical cadre that is the midwives. For me, Desmond, I would be very, very happy to see that we are empowering the midwives because we know the role that they have in the prevention and management of PPH. We empower them, we capacitate them, and then probably we keep track and see where we are going. And not forgetting, of course, our dear obstetricians, the medical officers, the lab technicians, everyone in their various capacities, because we know that PPH is a collective effort. So as I want to wind up, let us not forget about the midwife who died from her own very facility due to postpartum hemorrhage. In fact, for me, every time I think about Betty, it is one of the reasons why I so much put in a lot of effort, because we must know that PPH does not only affect communities that are very far from us, it can affect you as a health worker, and you can easily die from your own facility. So in the month of August, let's also pay tribute to Betty because she died due to excessive bleeding after childbirth. So to you, Dr. Isavi and Dr. PK, I usually call you Dr. PK, but he's Dr. Ponti and Chwanuka. Thank you so much for sparing off your time to speak to us. We have listened, and we do hope that collectively, as the theme says, we shall be able to implement. To Busoga Health Forum Secretariat, I think Dr. Paul is not here. Thank you so much for giving me an opportunity to speak, and looking forward to meeting all of you probably next month. Over to you, Desmond.
Thank you so much, Hadija. Unfortunately, you didn't thank me, but it's fine.
Oh, Desmond, thank you so much.
Okay, thank you. I want to, before I give the certificates, I want to tell members who are on call that Busoga from does pro bono clinics for those who are members of BHF, who subscribe to BHF. BHF is an institution that runs on membership subscription. So if you want to become a member, you pay 100,000. This money supports pro bono activities, and even run these CMPs that we are having. Institutions pay 500, and lifetime membership is 1 million. So in one of the pro bono activities we're having tomorrow, kindly, if you have a patient who is having an ear, nose, and throat problem, ENT, you know how scarce we our ENT specialties in the region. So Dr. Yusuf Fred, who is the head of ENT in Mulago National Referral Hospital and a member of BHF, will be giving free consultations and the basic treatment to the people who are going to go there. It is very free. So if you have a patient, let them go to Mafobera Center tomorrow, very early. The lane is always big. It is first come, first serve. Kindly go and get hope tomorrow. With that, this is a certificate signed by Professor Oiswa Peter, the board chair of Busoga Health Forum, and it's being awarded to Dr. Ponti and Chwanuka in appreciation for the remarkable presentation on ending maternal death due to bleeding after childbirth. That's PPH. A collective responsibility with a focus on Busoga region at Busoga from Friday being to date, signed by the board chair. This one goes to Dr. Isaiah Video, and you are also appreciated for this presentation. And Dr. Isaiah, thank you so much. I think I'll be in Namutumba next week. I hope to meet you. Thank you, team. We meet next Friday.
You're welcome.
Bye. Good evening. Thank you.
Thanks so much.
Alex Wanikla, could you inbox me? I'm putting my number in the chat. Alex from Namutumba. Members who missed the CPD link, I'm sharing it. It has been circulating. Kindly register your attendance in case you had missed.